Hello everyone. Today we'll be talking about the part 2 of our lecture series about PEEP, how to optimize the PEEP. And in this lecture, we'll look at the different methods for selecting PEEP. We already looked in the previous video about the physiological changes that occur when you change PEEP. Just to recapitulate, these would be changes in oxygenation, compliance, shunts and dead space, functional residual capacity, and cardiac output. So how do you select and optimize PEEP in your patient? Well, there are multiple methods to select the PEEP that you want to use, and these are the 5 most common methods that are used to figure out PEEP, and we'll discuss each of them individually as we go along this lecture. The first method to estimate PEEP would be using the ARDSnet escalation table. These tables have been used for many years and they have not been shown to be inferior to any other method of figuring out PEEP in terms of mortality or length of ventilator days. So if you are not well versed in the ventilator, this would be a very reasonable way to initiate the PEEP before you transfer the patients. These tables do not consider individual needs of the patient and are like one strategy fits all. They are based solely on oxygenation criteria, which may be misleading when lung protection is the principal concern. We know that changes in oxygenation are influenced by many other factors, such as VQ mismatch, and these are completely detached from changes in the lung mechanics or the lung tissue stress. The studies which have looked at the ARDSnet patients later have been shown to develop higher lung stress and alveolar hyperinflation. The first method of calculating optimal PEEP is maximize static compliance. The compliance, as you remember, is how much volume changes with change in pressure. So in volume assist control, if you're giving somebody a tidal volume of 400 cc's, you can figure out driving pressure by measuring the plateau pressure and subtracting PEEP from it. Hence, the static compliance can be measured by tidal volume divided by plateau minus PEEP, which is, in this case, around 33.3 centimeter. One of the things that you have to remember is that static compliance that you are measuring in this case is the static compliance of both chest wall and the lungs. Physiological rationale behind maximizing static compliance is recruited lung is more compliant, and the highest static compliance is possibly the optimal PEEP. The prerequisites for this would require a minimal spontaneous breathing in your patient. The reason for this would be if the patient is generating negative pressures, that can result in inaccurate measurement of your plateau pressures. So let's take an example. Here we have a tidal volume of 400 cc's and we are starting at PEEP of 5. You perform an inspiratory pause and measure plateau pressures and calculate compliance. You keep on increasing your PEEP in steps of 2 and 3. With every step, you perform an inspiratory pause and measure a plateau pressure and calculate the corresponding compliance. As you keep on going up, a point is going to come where your compliance is going to start getting worse. You come down to the point where the compliance was the highest, and that would be your optimal PEEP. One of the things you have to remember is when you change the tidal volume of the patient, you have to redo everything and you have to check your PEEP again for that tidal volume. There are a few problems with the technique. It takes time for the recruitment and de-recruitment to occur. At least wait a few minutes before changing the PEEP. The next method is staircase recruitment de-recruitment maneuver. And the physiological basis for this is PEEP causes recruitment and recruited lungs oxygenate better. This also requires the same prerequisites, that is minimally spontaneous breathing patient. So your patient have to be well sedated and comfortable and not fighting the ventilator. The first step is that you perform a recruitment maneuver, giving the patient 40 of PEEP for 40 seconds. Keep their FiO2 at 100%. And once 40 seconds are done, you drop your PEEP to 20. The first step is to decrease your FiO2 to target SATs of 90 to 92%. Once you have achieved this point, you go ahead and start dropping the PEEP down in steps of 2, and you are keeping an eye on the SpO2. And with every change in your PEEP, you try to wait at least 30 seconds to a few minutes And as your PEEP decreases, you would see that your SpO2 starts falling. You stop when the SpO2 falls less than 88%. To come back to the previous PEEP where your SpO2 was more than 88%. This would be your optimal PEEP using this method. Well, the main problem with this technique is risk of barotrauma and hemodynamic compromise when you are performing a recruitment maneuver. Since you are using the pulse oximetry probe, your saturation from the probe may not be constant. The next method to figure out optimal PEEP is using transpulmonary pressures. So let's understand what transpulmonary pressures are. The ventilator gives you the intrapulmonary pressures, and during the end expiration, the pressure should be around PEEP, and during end inspiration, the pressures reach the plateau pressures. This pressure is a combination of two pressures. These pressure inside the lungs have two components, one from the lungs and one from the chest wall. The real pressures that keeps your alveoli open would be the transmural pressure gradient across the pleural membrane. So let's take an example. If we have a plateau pressure of 30 with a normal chest wall, and let's say the chest wall comprises of 20% of the compliance, your component from the chest wall will be 6 centimeter water and from the lung would be 24, and that will give you a transpulmonary pressure of 24 centimeter. As your chest wall compliance worsens, your intrapleural pressure is going to increase, and that is going to be shown by increasing PEEP and plateau. So for example, in this case, if you have a stiff chest wall and now this component is around 50% of the compliance, the component from the chest wall is 15 and from the lung is 15, hence the transpulmonary pressures are much lower. We do not know how much of the pressure that we are measuring is from the chest wall component. So the only way to figure that out would be to place an esophageal balloon and try to measure the intrapleural pressure, and that would give you the transpulmonary pressures, which will be a better indicator how much these alveoli are really seeing. Let's take an example to clarify this further. We have got two lungs, one with a normal chest wall and one with a stiff chest wall, for example morbidly obese patient, and you are giving a PEEP of 10 to both of them. The intrapleural pressure in the normal person is measured to be around 5, hence the transpulmonary pressures are positive 5, that is 10 minus 5. This is keeping the lungs inflated. However, if you look at the patient with stiff chest wall, their intrapleural pressures are much higher. The transpulmonary pressure, that is 10 minus 15, is negative 5, and even for the same amount of PEEP, this lungs has got a transpulmonary pressure inflating the alveoli, and in this case the transpulmonary pressures are negative, which is cause alveolar collapse. Hence it is very important to measure the intrapleural pressures, because PEEP by themselves do not give you the additional information about what is really going on inside those alveoli. So what's the physiological rationale behind using this? The transpulmonary pressures are more accurate than plateau pressures as they remove the chest wall portion of the compliance, and a negative end expiratory transpulmonary pressure is interpreted as signifying alveolar collapse. On the top we have pressure time waveform from the ventilator, and you can look at the peaks and the plateau pressures and the end of the expiratory limb. The second waveform is the esophageal pressure, and if you subtract esophageal pressure from the intrapulmonary pressures, you get the transpulmonary pressures, and your target is to titrate the end expiratory transpulmonary pressure between 0 to 5 if your FiO2 is less than 50%, and about 5 to 10 if you are requiring high amount of oxygen. You can also use transpulmonary pressure to set your tidal volume to target an inspiratory transpulmonary pressure, that's the red line, less than 25 centimeters of water. And you can attempt to keep the tidal pressures less than 15 centimeters of water. So let's see how this is done. You got an esophageal probe which is measuring intrapleural pressure of 10 centimeter water. You have applied 8 of PEEP on this patient. Now you expected the PEEP to cause inflation of the lungs. However, the actual transpulmonary pressure is negative 2 centimeter. So if the patient is requiring lower fraction of oxygen, you can increase the PEEP to 12, and that would give you transpulmonary pressure of 2. This would be more optimal PEEP for a person requiring low level of oxygen. If your oxygen requirements is high, you can increase the transpulmonary pressure between 5 to 10. So you can go up on the PEEP further, say for example 15, which will give you a transpulmonary pressure of 5. There are various advantages of measuring the esophageal pressures, as it separates the chest wall compliance from the lung compliance, and thus it is great for the obese patients and patients with extrapulmonary ARDS. And you can use the knowledge from the esophageal pressure to figure out PEEP determination from the other physiological method that we have been talking about. The measurements of the esophageal probe can be a little tricky, as the pressure inside the pleural cavity depends upon the placement of the esophageal probe, and you're just measuring the pressure of the pleura near the left lower lobe, and it may not be generalized to the other parts of the lungs. And as you breathe in and out, the rise in the esophageal pressure can be very variable. Next method of figuring out PEEP is using pressure volume loops. Here the physiological rationale for using this is the lower inflection point represents the end of zone of tidal recruitment, and below which the tidal collapse of the alveoli occur and can result in the ventilator-induced lung injury. So keeping your PEEP at lower inflection point so that you do not get collapsed alveoli at the end of expiration. It requires a completely sedated and paralyzed patient, and it requires a very slow inhalation. And the reason for slow inhalation is you want to get rid of all the resistive component in the circuit. Since very low flow can result in long I time, people have estimated that using flow less than 10 liters per minute can give you a decent estimate of optimal PEEP using this method. It also requires 0 PEEP to start. So why do we need low flows using pressure volume loops? Looking at this example, this patient is getting a tidal volume with a 0 PEEP. As you increase the tidal volume, the pressure inside the lungs increases and it reaches the maximum, which is the peak pressure. And if you perform an inspiratory pause, the pressure will fall down to a lower pressure, which is plateau pressure. If there was no flow or slow flow, or there was no resistive component, the pressure volume will look similar to the one shown in the green. And the area in the red is the airway resistance, and the area in the blue is the elastic component of the circuit. If you increase the flow, you're increasing the peak pressure and increasing the airway resistance. And you can see that your lower inflection point shifts towards the right. So as you decrease the flow, your peak pressures will near the plateau pressure. And if your flows are very low, you can simulate a pressure volume loop with almost 0 flow. You draw 2 tangents as per the curve, and the intersection point will be your lower inflection point. Ideally, you want to go up by 2 centimeters of water above the lower inflection point, which is the optimal PEEP. There are a couple of other ways you can use your pressure volume loop to figure out where the optimal PEEP should lie. One of the method involves superimposed PV loops with different PEEP. We have got 4 PV loops with PEEP of 5, 10, 15 and 20. As you increase the PEEP, you see that the functional residual capacity increases, and this has got 2 components to it. One of them is because PEEP has caused hyperinflation, which is called end expiratory lung volume, and it has also caused some alveolar recruitment, which is shown in red. And as you increase the PEEP, you see that alveolar recruitment portion is increasing as well as the PEEP induced end expiratory lung volume. However, at a certain point, you do not see any more alveolar recruitment. The only thing you see is PEEP-induced hyperinflation. So you drop down the PEEP to the point where the alveolar recruitment stops. If you do not see any alveolar recruitment using this method, you do not really have to go up on the PEEP, as it will not result in any more oxygenation. So an upward shift of the PV loop signifies a recruitment. One of the other method is to examine the PV loop morphology. If you are looking at a convex PV loop with an upper inflection point, it suggests that there is a progressive decrease in compliance and you are reaching the overstretching area, and these guys will not benefit from increasing PEEP. If you are seeing a concave PV loop with lower inflection point, This shows there is an ongoing inflation during early part of the inflation, and these patients would likely benefit from the PEEP. If you got a linear PV loop, these patients may or may not benefit from the PEEP. The most important complication of PV loop is the patient can become very unstable when attempting these studies. Using slow flow and zero PEEP on a patient who is hypoxic can be troublesome. The other part of the problem is that the lungs is very heterogeneous and consists of different type of alveoli with different PV loops. The PV loop that you are seeing on the screen is a sum of the PV loops of all these different type of alveoli. The inflection point in the PV loop is not really very tightly linked to the alveolar recruitment, and this possibly represents beginning of significant recruitment rather than the optimal pressure for recruitment. And in many cases, you will not be able to even see a lower inflection point as the loop will be linear. The other problem with this method is there's a significant inter-observer variance about where these points are. So for example, you can draw different tangent line and get a different lower inflection point. Our next method of finding PEEP is using something we call stress index. When you examine the change in the compliance during the tidal ventilation, you can actually figure out if there is an overdistension going on. The slope of the airway pressure rise reflects the changes in compliance. The requisites for this method is a volume controlled ventilation with a constant flow pattern that is a square waveform. And just like the other methods, patients should not have any spontaneous respirations. In this case, you have to look at your pressure time loop. So when you give this patient a tidal volume, since you are on the straight portion of the pressure volume loop, the pressure rises uniformly over time as you give the patient some volume. If you had started with a lower PEEP, as you would have given the patient volume, the pressure would actually start sloping down as the volume increases, and this would be because the more alveoli are opening as you are giving the volumes. The compliance actually increases when you increase the volume. If you started a little higher on the PEEP, as you increase the volume, you are reaching the overdistension area where the compliance is very low, and that would result in increase in pressure for the same volume. So in fact, what you're talking about is looking at the stress at different point of the pressure volume curve and figuring it out on the pressure time waveform. So in this case, when there's a concavity of the pressure time curve, this shows that there is a decreasing compliance. That means there is increasing stress, and stress index is more than 1. If there's a convexity of the pressure time curve, that means your compliance is increasing, and that means your stress is decreasing as you give the volume, and the stress index is less than 1. And if it is straight line, well, there's no change in compliance and there's no changes in stress. You're possibly in the perfect zone. So to sum up, if you're looking at the upward concavity in the pressure time curve, that means your stress index is high. So you got to decrease your PEEP so that you can achieve a straight line. If you're looking at a downward concavity in the pressure time curve, you have to increase your PEEP so that you can get a straight line. In the Draeger vents, they have used the similar concept to come up with a number called C-20, which instead of stress, they look at the ratio of the compliance at the end 20% of your volume versus 80% of the volume. And if the compliance is same, it will be a straight line, just like the previous one we talked about, and your C-20 is going to be 1. If you have increasing stress or your compliance worsens, your C-20 is low, and therefore you have to decrease the PEEP. However, if your compliance in the end part is higher than the previous 80%, your C-20 is going to be more than 1. That means you have not used enough PEEP and you have to increase your PEEP. So using this C-20, you want to keep this number between 0.8 to 1. Another method of figuring out PEEP is monitoring the intrapulmonary shunting. As we talked in the previous lecture, one of the reasons why PEEP works in improving oxygenation is by reducing the shunt. However, if you keep on increasing the PEEP, a time is going to come where you're going to increase the intrathoracic pressure sufficiently high to shunt the blood out of the ventilated areas, and your shunt fraction will again start increasing. We have a shunt fraction of 67%. We have got 2 shunted alveoli and 1 normal alveoli. And as you increase the PEEP, you improve the shunt in one of the shunted areas, and your shunt fraction has decreased. However, if you keep on increasing, you are trying to squeeze the blood out of the normal areas, and your shunt fraction again starts going up. So your optimal PEEP is the point where your shunt fraction is the lowest. The other method you can use is figuring out the proportion of dead space, or VD by VT. We can calculate this dead space by looking at the PaCO2 minus end-tidal CO2. And as you increase the PEEP, the dead space fraction initially improves and then worsens as you overinflate. So for example, we have 2 alveoli, one with a normal alveoli with VQ of 1 and other with VQ of 0, which is a shunt. And as you increase the PEEP, you have recruited this alveoli. However, if you keep on increasing the PEEP, you are going to overdistend a normal alveoli, and you can create a dead space in that area. One of the newer method of figuring out PEEP that is emerging is called electrical impedance tomography, and this is a very interesting way of figuring out PEEP. It uses low frequency electrical current to figure out the conductivity of your body. So you put a series of electrodes around the chest wall, and you pass the current between a pair of adjacent electrodes and measure the voltage from the other electrodes. And you can do it in multiple stages. For example, you are giving current between 1 and 2, and then 2 and 3, and then 3 and 4, and so on and so forth, while you can measure this voltage difference between any of the two. This can give you a 3D diagram which can show you a pulmonary blood flow distribution and also the ventilation of the areas. So for example, in this case, we have got an orange area, which is area of alveolar overdistension, and a white area, which is the area of collapse. And as we increase the PEEP from 9 to 29, you can see that the alveolar overdistension increases while the alveolar collapse decreases. You can use this to plot a diagram which shows you different parts that you are interested in, things like relative overdistension, relative collapse, and dynamic compliance, and you can use this information to figure out optimal PEEP. There are a couple of things that you have to remember while figuring out PEEP with all the methods that we talked about. The first one of them is lung recruitment takes time. And in this study by CADS, they increased the PEEP from 3 to 13 centimeter of water, and they found that it takes at least 11 minutes for full recruitments to happen. In another study, a 30 centimeter of water pressure for 2 seconds can open up to 75% of the alveoli, while increasing the time to 40 seconds can increase this percentage to 85%. So you can see that it takes quite a long time before the recruitment happens. So it is optimal to wait for at least 2 to 3 minutes before changing your PEEP. PEEP measurements also depends on the tidal volume. So whenever you change your tidal volume, you have to come back and recalculate the PEEP. So for example, in this study, a volume of 7 cc's per kg, and they measured that the PEEP needed around 15 for the highest static compliance. But as you go up on the volume, you can see that the PEEP at which the static compliance is the highest drops down. PEEP effect is independent of proning. We have been using proning quite a bit for our ARDS patients. So you have to understand that both the methods, they work independently of each other. Most of the increased volumes in the PEEP are from increase in the end expiratory lung volume from the PEEP rather than recruitment. So in a lot of cases, you will see that your compliance is certainly better, but your oxygenation has not improved. The other thing you have to remember is risk and benefits of PEEP. So PEEP can reduce shunt and improve oxygenation, and it can also help prevent atelectasis trauma by preventing the opening and closing of the alveoli. It can reduce inflammation in the lungs as well. And we already talked about that it can improve the left heart failure, pulmonary edema, and can counteract auto PEEP. However, PEEP can also result in overdistension and worsen volume trauma. It can also result in barotrauma and worsen the venous return, and can certainly worsen the right heart failure. So how much PEEP do you really need? One of the things you have to remember with this PEEP is role of PEEP is not to correct the numbers, and you want to use the optimal PEEP to distend your alveoli just sufficiently so that you are able to recruit and oxygenate, but not to over distend, and you want to prevent the injury at all cost. In a very good article by Gattinoni, he aptly says you need to compromise among oxygenation, hemodynamic status, and intratidal opening and closing of the alveoli using PEEP. So bottom line, keep your tidal volume slow, keep your plateau pressures less than 30, assess the recruitability in all patients, find your optimal PEEP using different methods that we talked about, and then balance risk and benefit of increasing PEEP. And you want just enough PEEP to oxygenate and minimize the ventilator-induced lung injury. You have to understand that different patients have different needs. Understand what are the advantages and limitations of each methods that we talked about, and trying to figure out which physiology is predominant in your patient and what you really want your PEEP to do for you. Use a combination of these methods with a goal to optimize oxygenation while minimizing the lung injury. It is said that PEEP level that avoids intratidal recruitment or de-recruitment provides best compliance, best oxygenation, lowest dead space without causing hyperinflation and worsening hemodynamics is almost unachievable. Best PEEP in fact does not exist, but a better PEEP does.